This podcast is brought to you by the Association for Child and Adolescent Mental Health, ACAM for short. You can find more podcasts and other resources on our website, www.acamh.org, and follow us on social media by searching ACAMH.
Hello, welcome to the In Conversation podcast series for the Association for Child and Adolescent Mental Health, or ACAM for short. I'm Jo Carlo, a freelance journalist with a specialism in psychology. Today I'm interviewing Dr. Andrés Martin, Riva Ariella Ritvo Professor at the Child Study Center and Director of the Simulated Participant Program, SPP, Teaching and Learning Center TLC, Yale School of Medicine, Dr. Jose Paez, also of the Yale Child Study Center, and Dr. Doron Amsalem, Child and Adolescent Psychiatrist and Assistant Professor of Clinical Psychiatry at Columbia University. All are co-authors of the paper Destigmatizing Perceptions about Black Adolescent Depression, Randomized Control Trial of Brief Social Contact-Based Video Interventions, recently published in the Journal of Child Psychology and Psychiatry. The paper will be the focus of today's podcast. The JCPP is one of the 3 journals produced by the Association for Child and Adolescent Mental Health. ACAM also produces JCPP Advances and CAM. If you're a fan of our In Conversation series, please subscribe on your preferred streaming platform. Let us know how we did with a rating or review, and do share with friends and colleagues. Andrés, Jose, and Doron, thanks for joining me. Can you each start with a brief introduction on who you are and what you do?
Thank you very much. I am Dr. Andrés Martin, and pertaining to this paper that we're going to be talking about as director of the standardized simulated patient program at Yale, we're going to be talking about 2 of the simulated patients who participated. And I should add that we're especially proud that both of these actors are underage. They're under the age of 18, which is something special in the simulated participant world. And I am happy to pass the baton on to my good friend and colleague, Dr. Doron Amsalem. Doron?
Hi, thank you and for having us. My name is Doron Amsalem. I'm a child psychiatrist. I work in Columbia University as a research scientist. I study stigma, and I'm happy to be here.
Thank you, Doron. And Jose?
So my name is Jose Paez. I'm a child psychiatry fellow at the Yale Child Study Center, and I work with Dr. Martin and Doron on this paper. Thank you for having us.
Well, let's turn to the paper, Destigmatizing Perceptions about Black Adolescent Depression, Randomized Control Trial of Brief Social Contact-Based Video Interventions, recently published in the JCPP. What did you look at in this study? Can you give us a summary?
Absolutely. Depression is highly stigmatized in adults, and we know in adolescents as well. And the repercussion of this is that adolescents are reluctant to share their symptoms of depression, and even more reluctant to seek treatment or to stick with treatment. Mm-hmm. Depression can lead, in the worst of outcomes, to suicide. And suicide is one of the leading causes of mortality in this age group. So the stakes are high to destigmatize this disorder.
Absolutely. And why was it important to focus on Black adolescents in relation to depression? Can you set the scene for us?
Absolutely. In an earlier paper, also on JCPP, with Doron as a first author, we had found that a short video clip of an adolescent talking about their depression, how they then sought treatment, and how they regained their baseline functioning. We found in that paper that a video showing that led to decreases in stigma and increases in treatment-seeking intentions when compared to a control video in which the same adolescent talked about something unrelated to depression. We were thrilled with those findings and with getting it published in JCPP, the leading journal in child psychiatry, together with JCAP, its American counterpart. And one of the secondary findings that surprised us is that Black adolescents had a response that was about half as strong as white adolescents. So going into this paper, our original hypothesis was that if we had now a Black adolescent as compared to a white adolescent in the first paper, that Black participants would respond more strongly and that their response would be similar to that we found in white adolescents in the same paper. I will leave the cliffhangers here and say that that's not what we found, or not completely what we found.
Can you say something about the methodology that you used for this paper, for this research?
Yes, and I'm going to pass the baton to Doron, who really has been a pioneer in this particular methodology. Doron?
Sure. So as Andres described, we using short videos to test change in perception, and the way we do that, we created videos very short in length, and then we run it by a crowdsourcing platform. We usually have between 1,000 and 1,200 participants for each of our studies. In that specific study, we had 1,093 adolescents, ages 14 to 18. As I said, using crowdsourcing platform and conducting the study online.
Can you describe the types of brief contact-based video interventions that we used in the trial?
I'll first say that we randomized different videos, and Doron, take it away.
So the first one was a video of a Black girl describing a story of depression, which was used in a previous study presented by a white girl. So it was a story about depression and how treatment helped me to recover, but not accounted to any race-specific characteristic. The second one was presented by the same Black adolescent girl, now accounting for race characteristics, and basically describing how is it to be a Black girl with depression and how treatment helped her to recover. And the third video was a control video with a story that wasn't related to depression at all.
What was the age of the girls?
16.
16, thank you. And what differences did you find in terms of stigmatized attitudes and help-seeking intentions between the different groups?
So about basically the results. So following the intervention, the stigma scale, the depression stigma scale that we measured was changed from baseline to the post-intervention across all three conditions. But in terms of differences, the adjusted video showed the greater reduction in stigma. So the video that was accounting for race characteristic differences was the one that showed the biggest change. The second level of outcome was temperature toward or warmth toward the color of the presenter. And what we saw, which was a big surprise for us, that the biggest change was among white viewers when they watched the adjusted video. What we concluded was that when you watch a story in a way that was surprising for you, they didn't know or they didn't realize what race has to do with depression or how it relates to depression. So then you basically showing the biggest change from baseline. So that basically was the second result.
Can I just get a sense, if you were to put it in lay terms, then what would be the kind of experience that would be described in the script that participants would be watching?
So I should say that the adjusted video was informed by a focus group of 6 Black women. There were no white people involved in their conversation. And what came out of it, which was extremely surprising, and I would say, as you heard from Doron, much more surprising to people like myself who are white. What was surprising were 2 things from that focus group, which we then incorporated into the adjusted video. The first one, counterintuitive and surprising to me, was how important hair was in the case of Black girls. They felt that from a young age, they were subject to this sense that curly Black hair is not as quote unquote beautiful as, let's say blonde or otherwise non-Black hair. And that they had internalized that sense of difficult perception about themselves. The second finding, which is in retrospect not surprising at all, was the role of racism, anti-Black racism in their depression. That this was a very important contributor that does not apply to white girls. And we incorporated both of these findings into the adjusted video.
Can you explain what a race by intervention interaction entailed in the context of this research?
So let me take the first half of it, and then I'm going to pass it to Dr. Paez. What this means is that depending on your race, you responded differently to the intervention. Mm-hmm. If you were a white viewer, you responded more strongly, which was counterintuitive to us. And that was because, as I said, being a white person, we were surprised to know the shocking difference and to know the internal experience of a Black girl with racism. I will let Dr. Paez say a little bit more about that. And let me just add that I am a white man. Dr. Paez is an Afro-Caribbean man. And I'll be interested in his take on this. Jose?
Thank you, Andres. I think the second part to this answer really has to do with what the participants or the people looking at the videos had been exposed to previously to the study. So when we think about issues of mental health, we really are exposed to those that are around us. And if you don't surround yourself with people of other races, then you would be very surprised to see how they experience depression and how that differs from the way that you experience depression. So I think that the mere exposure of seeing somebody of a different race in a similar distress, but not necessarily because of the same thing, like Dr. Martin said, it's quite shocking. But I also think it goes beyond mental health. Dr. Martin touched on the subject of racism. And I think it also touches on that. And I think it creates a more even playing field, even for the field of mental health, to know that people, regardless of their race, have struggles that are unbeknownst to us.
I should add that one of the counterintuitive findings was that Black viewers responded the same to both of the Black videos, to the normal depression and to the adjusted depression. We had not predicted this. We had predicted that Black individuals would respond much more strongly to the adjusted video. And the way that we explained this is the hypothesis, the sense that if you are Black, you really are not surprised. You are not surprised to know the pervasiveness of racism. I knew that. What's so surprising? And a difficulty to really disentangle depression with or without explicit racism, because they know that racism is embedded, whether explicit or not.
Yeah, really interesting. You've already shared quite a few findings. Is there anything else you can share from the results?
Yes, one of the things is future directions. And we just had a manuscript accepted and published that extends these findings with a different population. And once again, my colleague and trailblazer, Doron, took the lead on that article. So I'm going to pass the baton to him. Doron?
In both papers, the mechanism of action, the way it works is basically social contact, which means if you expose someone and someone is, honestly and directly share his experiences, people can identify with and emotionally engage, and that's what basically creates the change. So we did a similar study with a similar mechanism, which means we created the videos depicting of young transgender adolescents, and they described their story and how they coped with depression and even suicide ideation, and how treatment helped them to feel better. And we use similar measurements to understand depression stigma and help seeking. And we were able to show that when transgender adolescents describe their symptoms, so first we see similar results in terms of changing depression stigma, but also reducing transphobia, which was a great outcome for us.
Has that been published yet?
It was published to our delight in JAMA Open Access, and it had an accompanying, really thoughtful editorial by Jack Turbin as a senior author. Jack is one of the world experts on the mental health of transgender adolescent youth. So we were thrilled about that finding. And I should just add that similar to the paper we are discussing now, straight viewers responded much more strongly than LGBTQ viewers. As you can imagine, even though we had a large sample of over 1,000, we had too small a transgender youth viewership, but we're essentially certain that they would not have responded in as strong a way. I am a straight white man, how we responded. And once again, it had to do with shock, if you will, of meeting a transgender adolescent. And when I say shock, it was a positive shock. It was, oh my goodness, these transgender youth are youth who wake up and brush their teeth and go to school, and they're wonderful kids. And for some people, this was the first transgender person they had ever met.
So it's about sort of exposure and dissemination of people's lived experiences. That seems to be important here in terms of stigma.
Absolutely. Which goes back to the exposure to a world, a population, issues that you don't know, whether it's racism, whether it's transphobia, etc.
It's really interesting. It's just focusing on the JCPP paper that we're talking about today. Is there anything else that you'd like to highlight?
I think that there is such a pervasive sentiment of racism, and specifically anti-Black racism, whether overt or not overt. Once again, I'm going to pass it to Jose, who is an Afro-Caribbean man, will explain, as I said, an experience that is very alien to white men like Doron and myself. Jose?
Thank you. It goes back to what Dr. Martin was talking about, which is the exposure factor of being, seeing the suffering, in a race that you're not used to seeing it. And that really goes a long way. I think as humans, we have a lot of tribalistic thinking. And when we recruit others into our tribe, we tend to be more understanding and more protective. And, mental health, it's so prevalent.
Sorry to interrupt, Jose. May I ask you to just add about the issues in the United States as opposed to other countries, and the very serious skeletons in the closet that we have in this country, the original sin, if you will, of this country?
I think that comes back to the exposure. For hundreds of years, African Americans and minorities in this country have had to hide their struggles with mental health for various different reasons, be it cultural or be it that they didn't necessarily meet criteria to address it at the moment because they had other concerns to address, like food, shelter, equality. So I think we're at a point where different peoples in this country, from different races, can start to address these things, and it's something that's long overdue. And it's going to take time for, the majority, the race of the majority to realize that. Just like them, we also struggle with mental health issues and also go through similar plights. So it's not what it used to be.
Let me add something, and even if it's not smoothly connected to what Jose said, but I do want to add something about the United States. I should add that in the United States, where we did the study, there's an important additional issue to mention, and that is that for 400 years ago is when the first African slaves were taken to this country forcefully. Since then, over the 400 years, we have experienced anti-Black racism in different ways. Obviously, the first and most terrible one was slavery. But when slavery was ended as a result of the Civil War, as we all learned, related to Abraham Lincoln, that doesn't mean that overnight after abolition, anti-Black sentiment ended. To the contrary, we then went into a different era of difficulty, first in Reconstruction, then in the terrible years of Jim Crow, in which the racism was different. Slavery was over, but it was very explicit. White drinking fountains, Black drinking fountains. There are countless examples. When that was done, after that, Jim Crow formally ended, quote unquote. Martin Luther King, of course, the hero. But that's not when racism ended. I would say that racism then went into a pervasive, insidious, more invisible type of racism, redlining. You can live here, but you cannot live there. You can get a loan, you cannot get a loan. And that has slowly led into the current stage of racism, which is not explicit. It's certainly not enshrined in the law, but being a Black person, individuals have to fight in ways that we white people take for granted and do not know. And whether it is implicit or explicit bias, whether it's microaggressions, which, by the way, I have been taught by my Black colleagues, including Dr. Amanda Calhoun, who is one of the co-authors of our study, Microaggressions is a misnomer. I would say that microaggressions really should be thought of as everyday racism.
All of which has implications for mental health.
Absolutely.
Importantly, then, for our listeners, what are the implications of your findings for CAM professionals working with racially stigmatized groups?
I would say that if I could give one practical thing to myself and to all of my colleagues, is the following. Ask about racism. That's not a bad word. It's not a hidden word. It's a critically important word. And the way to ask can be very simple. Have you ever experienced racism? Please tell me. I think that that's important. Jose, how would you ask about racism?
I think the best way is just to be direct about it, because the more words we use to disguise it, the less genuine it comes off of. It comes through as. So asking directly about racist experiences that they've had and how it has affected their lives. And I think it's something that Dr. Martin said it. It's very pervasive and it's quite insidious. So there are things that you may look back on, and me myself, sometimes I look back at things and I realized only later on that it was racist. And then I'm left holding that baggage. If my therapist would ask, then I would be able to talk about it. Kind of like one of those things where you look in the mirror and say, if I was there again, I would say this. So therapy would allow you to do that. Mental health professionals can do that, depending on how they ask the questions. And I think that it's just being very direct and not dancing around the bush.
Do you think many CAM professionals shy away from asking?
Yeah, 100%. Yeah.
And I would start by blaming a child psychiatrist who I know very, very well by the name of Dr. Andrés Martin, me. Mm-hmm. Before these studies, before doing this work in anti-Black stigma, where I go back to Dr. Amanda Calhoun, a real pioneer in this and a proud Black woman. Before knowing this, I did not ask. I was concerned. I thought it was, inappropriate going to places that were none of my business. I have changed my mind. I have started practicing in that way. And I think that I'm a better child psychiatrist as a result. Let me just add very quickly that although this study was focused on anti-Black racism, that for sure is not the last type of anti-X sentiment. Mm-hmm. I am a native of Mexico, and my colleagues, some 20 or 30 million in this country alone, experience anti-Mexican, anti-brown sentiment. We could talk about anti-Asian sentiment. We can talk about xenophobia. We can talk about many, many things. And although there are some singularities to the US experience, certainly this is not just a US phenomenon. Racism, anti-X sentiment is painfully alive and well everywhere in the planet.
Thank you. And are you planning some follow-up research that you can share with us? I know you've talked a little bit about your work with transgender youth.
Let me briefly say, and then pass it on to Doron, the findings on transphobia and improvement of transphobic perceptions, if you will, was a diagnostic paper. The intervention was helpful, certainly, but it was a brief intervention, and we think that we can extend those findings in a different and very practical, in the real world way, that we can take not just to the 1,000 participants in the study, but throughout. And so let me pass it to Doron and talk about this current randomized controlled trial.
Sure. So this is a study that we're conducting among healthcare providers, and that including basically a training and few arms. This is a randomized control trial, and one of the arms is the, as usual, training of how to approach adolescent youth. And we added to the intervention arms short videos with the participation of transgender adolescent who describe their experiences in the same mechanism that we just described. And the third arm is basically the same training and the same videos, but now also with transgender educator that do the training themselves. And we measuring differences in both transphobia or stigma and how well the training went. This is still a bit early to discuss the results, but we're definitely excited about it.
Great, thank you. Doron, can you tell us about the use of TikTok? That sounds very exciting.
At the end of the day, the short videos basically creating the the daily life of our younger people around us, and they watch short videos all day long, basically. And we try to create content that eventually will help to reduce stigma and to encourage people to seek help. And the best platform to do that is where they spend their time, right? It's either the Instagram or TikTok. So we basically now studying ways to replicate the same studies in the TikTok environment.
Thank you. Finally, what is your takeaway message for those listening to our conversation today?
Yes, Joanne, if I were to summarize all of these studies and everything that we've done, would be summarized into what I say are the 4 words that summarize this field that we're privileged to be a part of. It applies to the broader house of psychiatry and maybe of medicine, but certainly of psychiatry and child and adolescent psychiatry. And that is that 90% of our job is to make things talk aboutable. And in this case, it is anti-X sentiment, anti-Black sentiment, anti-transgender sentiment, et cetera, et cetera, et cetera.
Brilliant. Thank you ever so much, all of you. For more details on Doctors Andrés Martin, Jose Paez, and Doron Amsalem, please visit the ACAM website, www.acam.org, and Twitter @ACAM. ACAM is spelled ACAMH. And don't forget to follow us on iTunes or your preferred streaming platform. Let us know if you enjoyed the podcast with a rating or review, and do share with friends and colleagues.
This podcast was brought to you by the Association for Child and Adolescent Mental Health, ACAM for short.